Hello, my name is Adam Manis. I'm a sports medicine doctor in downtown Toronto, and I'll be giving you a dermatology review as part of the sport and exercise medicine review. So, a little bit of background about this talk, which will focus on skin and soft tissue infections in sports medicine. So these are the most common group of infectious diseases in athletes. One stat that I found showed that they were responsible for over 50% of all reported infectious diseases in athletes. They're responsible for 8.5% of high school sport-related conditions and over 20% of college-related sport conditions. These are conditions that can happen to anyone, but you do have to be aware that they can be, or they are more common in sport people, and this is most likely due to some of the risk factors, such as skin-to-skin contact, contact with athletic equipment, and possibly mats. The skin trauma, that's certainly a risk factor for a lot of these infections, and possibly also the sweating and inclusive clothing that's used in these sports. And these skin conditions are more common, particularly in wrestling, football, rugby, and judo. So basically what we're going to go through are some of the more common conditions that you might be encountered with as a sports medicine doctor. And a lot of the management diagnosis of these conditions are not necessarily specific to sports medicine. It's a little bit more of a review of common derm conditions, but a couple of quick notes that are more specific to sports medicine. So the first thing is that you will potentially need to familiarize yourself with your sport or federation's rules, depending on which teams and which athletes that you're covering as a sports medicine doc, particularly in the martial arts. And the other thing to note is that there is pretty much a lack or limited evidence for any interventions for preventing these types of infections. So in this regard, what I would recommend is trying to promote and practice reasonable interventions that are probably beneficial to some degree, but certainly even if they're not, they're probably pretty reasonable things to do for other reasons, such as wiping down mats and not using and sharing water bottles and other equipment and stuff around the locker room. So the different conditions we're going to go over, you can see on the slide over here. So basically, going to go over a few viral conditions, go over some fungal infections, and then finish off with some bacterial infections. Don't have any disclosures. So if we get into it, we can start with some viral infections. So the first one is herpes gladiatorum. You can see a picture up there of these clustered vesicles associated with an infection. You can have fever, reactive lymph nodes, as well as a sore throat. So this is more than just a light isolated skin infection. You can actually be systemically unwell. You can get these types of outbreaks from herpes simplex virus 1 or 2. So 1 is usually more common around the mouth, and 2 is typically more of a genital infection, but either of these ones can also occur anywhere on the body and can commonly happen in wrestlers due to the skin contact. Now, whether potentially secretions or inanimate objects, particularly wrestling mats, can be a source of infection is not fully determined. Differential diagnosis would include other viral infections such as shingles as well as or molluscum contagiosum. You can confirm your diagnosis with a viral culture, although this is not always necessary if it has a very typical appearance. And the treatment is to treat these outbreaks with antiviral medications, oral antiviral medications. And we're not going to get into too much detail here today, but there might also be a role for regular prophylactic oral antivirals for preventing reactivation or outbreaks, recurrences of this type of infection. And there may also be a role of taking regular suppressive antiviral medications to prevent asymptomatic shedding of the virus. So there is potential for actually transmitting the virus even when you don't have a rash if you've had it before. Second condition is molluscum contagiosum. So you can see in the picture here the characteristic, the quality that really defines these lesions is this dimpled appearance of erythematous papules. And compared to the herpes simplex viruses, it seems like this is better understood that it can be passed on with inanimate objects, which can include mats, towels, as well as razors, and can also be spread by skin-to-skin contact. Differential diagnosis would include some of those other viral infections that we talked about on the previous slide. A little bit tougher to get to confirm the diagnosis with any diagnostic test, but if you really need to, you could do a biopsy, but that's usually not necessary. And the treatment for this type of infection includes a lot of different options. One thing you could do, depending on how quickly you need to get rid of the rash, is just wait, because usually it'll resolve on its own in about a couple of months. And other quicker treatments include cryotherapy or liquid nitrogen, and some other creams and medications that you can see listed on that slide. So next we're going to talk about some fungal infections. So these are the tinea infections that can be over the body in non-specific locations. For tinea corporis, it can be over the scalp for tinea capitis. You can have tinea cruris in the groin region and tinea pedis over the foot, and particularly in between the toes, as you see on the picture in the slide there. So these rashes are characterized by pruritic erythematous plaques. They typically have a central, or they can have a central clearing, and they often have these raised borders, raised and irregular borders. You get these infections. You can certainly get them by skin-to-skin contact, and again, it's generally thought that these can be, particularly for tinea pedis, that you can get that from by walking around barefoot in locker rooms without wearing your shower sandals, but I couldn't find any convincing evidence that this actually is the case. Differential diagnosis would include eczema, different fungal skin infections caused by candida, as well as scabies. You can confirm your test once again with not once again, but you can confirm your diagnosis with a potassium hydroxide skin scrapings, as well as potentially with fungal cultures, but usually you can make this diagnosis clinically without doing these tests. And the first-line treatment for most of these types of infections would be topical antifungals, and usually these are pretty effective. And if they're not, or the rash is really widespread, sometimes you can go ahead and use oral systemic antifungals. There's a few more pictures of some tinea fungal infections. So you can see in the picture on the left, the armpit would be a pretty typical location to get this type of infection due to the moisture from the sweat. And just the skin folds over there, and you can see the central clearing and the raised red borders over there. And on the right side, you have tinea infection in the groin region. So you've got some tinea cruris over there. So now we're going to move on to the bacterial infection. So we'll start with one of the most superficial type of bacterial infections, impetigo. So this has a typical clinical progression where they start off as these papules that can turn into vesicles, and in non-bullous impetigo, the vesicles will commonly turn into these honey crusting appearance after the vesicles have popped. And in bullous impetigo, the vesicles progress into these bullae. And you get this type of infection from direct contact, and can also come from indirect contact. So you can get a secondary infection of a primary skin condition, such as eczema. The differential diagnosis would include eczema without secondary infection of impetigo, cellulitis, as well as potentially herpes, as well as other different conditions, as you can imagine. Once again, this is usually a clinical diagnosis. You could culture if this type of infection, particularly if you had bullae or vesicles, and culturing this type of skin condition might be important if you are suspecting MRSA infection. The treatment would typically be with topical antibiotics, and these are usually effective. And if they're not effective, or if you have a more widespread infection, the next line therapy would be systemic oral antibiotics. The next skin infection that we're talking about, and I guess I've grouped it here with the bacterial skin infections, although it doesn't always have to be bacterial, by getting a little bit deeper than the impetigo is a folliculitis. So the characteristic clinical feature is that these lesions are going to be found at hair follicles, and you're going to have pruritic, painful papules, as well as potentially pustules. And this is due to an inflammation of the hair follicles. And most of the time it's infectious, and it can be bacterial, it can also be fungal or viral, but most of the time when it is infectious, it is bacterial. And you can also have a non-infectious folliculitis where you've just irritated the follicle, and then you get the similar appearance. You can get this sometimes after shaving. And then you can also get a hot tub folliculitis. Differential diagnosis includes acne, rosacea, as well as perioral dermatitis, particularly if it was confined to the region around the lips. Once again, this is usually a clinical diagnosis. You could do a culture or a gram stain, particularly if there was any pustules. First-line treatment could include some watchful waiting if it was pretty mild and not causing the patient too much trouble. Other reasonable options would include topical antibiotics. It'd be pretty uncommon to use systemic antibiotics for a folliculitis. And then if the rash wasn't going away, with a trial of topical antibiotics, you might want to think about either antifungals or antivirals, or potentially getting some advice from a dermatologist at that point as well. So then you have some of these other skin infections that I myself think of as bigger folliculitis. So going in order of size, after a folliculitis, you can get a furuncle. So this is basically just a deeper folliculitis. You get this nodule, so you can see that lesion over there on the bottom left, and these can be pretty painful. And then if that progresses even further, or if you get the coalescence of multiple inflamed follicles, you get a carbuncle, which is the picture over there on the right. So you can see a bunch of different collections of white pus over there that have coalesced, and often with those you'll get spontaneous purulent drainage. The treatment for these guys is different in that if you feel like you have any fluctuant mass, you should definitely do an incision and drainage, and then you might end on antibiotics, particularly if there was associated cellulitis or any systemic associated symptoms, particularly a fever. Next, we'll talk about cellulitis, which is once again a bacterial skin infection, but with the cellulitis, it's a deeper skin infection of the deeper dermis as well as the subcutaneous fat. Characteristic appearance is these warm erythematous plaques that can be indurated. They're often painful as well, and you can get these as a primary infection, and you can also often get these secondary to a disruption of the skin barrier, such as an abrasion or a laceration, which a lot of the sports and these athletes would certainly be at risk for. Differential diagnosis would include DVT, so you certainly wouldn't want to miss a DVT in a lower leg warm erythematous plaque that you weren't 100% convinced was due to a cellulitis. You also want to think about, or at least look for the possibility of deeper skin infections that might have different treatments. It could also be look like insect bites as well as allergic reactions. So once again, usually no diagnostic test is necessary to confirm this diagnosis, but you might want to think about cultures, particularly if there's any associated abscess or any drainable collection. You might want to think about an X-ray if you're worried about a much deeper infection, such as gas gangrene or necrotizing fasciitis, where you could see gas formation, and an ultrasound might be useful if you thought there might be a deeper collection, such as an abscess, or a Doppler ultrasound to rule out a DVT. First-line treatment would be systemic oral antibiotics and sometimes even intravenous antibiotics, depending on systemic symptoms and the extent of the infection, possible comorbidities as well, such as diabetes. And then obviously you'd want to always do an IND if you had associated abscess. The last condition we're going to talk about is community-acquired MRSA. It's not a particular skin infection, more of a particular etiology of a skin and soft tissue infection. These characteristically appear less so as cellulitis and more as the bacterial infections that present as collections, such as folliculitis, furuncles, carbuncles, and abscesses. They're thought to be transmitted by the colonization of either the skin or the nares from a carrier, so a contact person, and they can also be passed on by inanimate objects. Differential diagnosis would include methicillin-sensitive Staph aureus skin infections, as well as spider bites. So these are commonly mistaken, these can commonly be mistaken for spider bites. Confirmatory tests would certainly include cultures of the pus, if there was any pus to collect, and then it would also be possible to culture the nares of someone that you thought might have an MRSA skin infection but didn't have any local collection that would be reasonable to culture. But then the problem is this just an incidental finding of someone who's MRSA positive from their nostril, or does being MRSA positive in the nostril mean that whatever other skin infection they have over their body is due to MRSA? So you need to take everything into account and potentially their response to certain antibiotics before making this conclusion in this circumstance. And the management would be systemic antibiotics that could be either oral or intravenous, and the most common effective antibiotics that work against this type of bacteria are your sulfotrim, your doxycycline, and your clindamycin. And one last time, if you did have a collection of drainable infection, you'd want to do an incision and drainage as well. So here are some of the review questions that I came up with for you guys. So the first question True or false? Skin and soft tissue infections are the #1 cause of infectious diseases in athletes. Second question, another true and false. Furuncles are bigger than carbuncles. Third question, name an appropriate choice of antibiotic for community-acquired MRSA skin infections. Next question, which features differentiate molluscum contagiosum from Herpes gladiatorum? And the last question, another true and false question, systemic antifungals are the first-line treatment for tinea corporis. So that's the end of my talk. Hopefully it was a useful review of some common skin and soft tissue infections that you can see covering athletes and teams as a sports medicine doctor. And thanks for listening.